Radial access begins using ultrasound to visualize the radial artery. Then the subcutaneous and periarterial tissues are infused with lidocaine under continuous ultrasound visualization. The radial artery is then punctured using a 21 gauge needle via single wall technique, and confirmation of arterial access is confirmed with return of arterial flow. A guide wire is then introduced via the access needle, and care is taken not to push through resistance. Gentle pressure is then applied over the artery while the radial access sheath is threaded over the guide wire. Careful pressure. A tegaderm is then used to secure the access sheath. At this point, the vasodilatory cocktail is injected via the access sheath after mixing it with arterial blood. Following this, a radial arteriogram can be used to visualize the brachial and radial artery to confirm no anatomic variations are present. Next, a Simmons 2 catheter is threaded over a guide wire, which is introduced to the radial artery via the sheath. Then, if the arteriogram of the radial and brachial arteries shows that there is favorable anatomy with no tortuosity or loops, then the wire and catheter are slowly advanced together under live fluoroscopy into the proximal brachial artery while monitoring for any sudden changes in direction that could indicate a branch point in the brachial artery. And once the wire and catheter have been successfully navigated into the proximal brachial artery, live fluoroscopy can be used to navigate the subclavian artery and enter the aorta. Our preferred method of forming the selective catheter is across the aortic arch, without reflecting the guide wire off of the aortic valve. This is accomplished in several steps. First, the guide wire is navigated into the descending aorta, and at this point the catheter is then advanced until its secondary curve is at about the position of the peak of the aortic arch. The guide wire is then retracted while carefully and slowly rotating and applying forward pressure to the catheter, which will cause herniation of the formed catheter into the ascending aorta. Here is an example of forming the selective catheter across the aortic arch in this patient. Once catheter formation is complete, diagnostic cerebral angiography typically proceeds in a left to right order. At the conclusion of the procedure, an inflatable radial artery band is used to achieve hemostasis. To accomplish this, the band is placed over the radial access site, the balloon is fully inflated over this site, and the sheath is then removed. The band is then slowly deflated until a flash of bleeding occurs. At this point, an additional 2 milliliters of air is used to re-inflate the band and stop the bleeding. This level of inflation is then maintained for 30 minutes in the setting of diagnostic procedures and for up to 2 hours after interventional procedures, and then a deflation protocol slowly releases pressure with confirmation that no bleeding occurs during this procedure.